avulsion is a relatively new technique that lots of people are interested in, like how do I do this? When do I do it? So in the past, the paradigm that was used to perform EMR was that we would start off with snaring the entire lesion, but sometimes during the snaring process, I should say it's really more than sometimes, it happens pretty frequently, you encounter some portion of the lesion that is so flat or has enough underlying submucosal fibrosis that you just can't get a hold of it with a snare. So you would end up with, say, 95% of the lesion snared, and then you've got 5% that has this very flat or fibrotic nature to it. You just can't get a hold of it. So then what do? In the past, what would happen was that people would often get out an ablation device, most commonly the argon plasma coagulator, and burn that area up. But we have good evidence that if you do that, that results in a higher recurrence rate at follow-up. The problem is that you're sort of subjectively burning that tissue. And how do you know whether you've gone deep enough to destroy it all? So we've now replaced that idea of ablating that flat or fibrotic tissue with this technique that's called avulsion. And it's done with forceps. You can use hot forceps or cold forceps, but basically you're going to grab that tissue and pull it off. And when you pull all the tissue off, you basically have removed it in the same plane in which you were snare resecting. And at the end of it, it doesn't look like some burnt up tissue. It looks the same as the snared area. In hot avulsion, we use a cutting current or soft coagulation current to limit the thermal injury. And the technique is to grab the tissue, tent it, and then apply the cautery and pull it off. There's a separate technique that uses cold forceps called CAST, C-A-S-T. In this technique, you grab the tissue, pull it off without electrocautery, and then take the snare tip set on soft coagulation and burn the base. Both of these have been shown to be effective. Unlike that process of ablation, avulsion does not result in a higher rate of residual polyp at follow-up. So now the new paradigm of EMR is snare everything you can. If there's some portion you can't remove, avulse it. And that's how you complete the removal of the polyp. Don't ablate anything that is obviously polyp.